Welcome to Let's Talk About Mental Health. I'm Nels Kloster. I'm an addiction psychiatrist and I work in Southern Vermont.
And my name is Robert Stack. I'm a licensed alcohol and drug counselor, a licensed mental health counselor. Good.
Yeah, and we thought we'd talk about current events today. I mean, two things that have been in the news are a lot of press about the marijuana legalization bills, and of course opiates are ever present in the news, and as well we just read a fascinating article in the New Yorker about some new theories about schizophrenia that we thought might be interesting to share.
And on that same theme, I was watching our community TV, and they recently had a show sponsored by a local radio station, WKVT, called Call to Action. And this was about mental health. It also talked a little bit about addiction, which, it's funny when you and I talk about addiction is mental health. Right. But somehow we separate it out and we say it's something different, but it's not. It's all part of it.
Yeah, it's unrealistic to separate the two, given how entwined they are.
That's right. So that's a great program, and it's currently being shown on. One way to find it is to go to brattleboro.tv.org. And then you can find the show. It's WKVT, a call to action. I think it's really informative. They have somebody from our local mental health, HCRS, and some other good stuff. And one other film I saw, and I was really surprised by it. It was around the struggle with the opiate epidemic. And they were talking about opiates and treatment and people, and they were interviewing family members, interviewing people in recovery. And to my surprise, it was done by the FBI. It was an FBI film. So I guess some people could accuse it of being propaganda or whatever, but I thought it was really well done. In some ways it was really sad because they had a couple family members who lost their children to overdose. And especially when you hear and I recently was talking to some folks up in Orange County that, it's such a heartbreaker when people go into treatment and they come back and they relapse. Mm-hmm. And people are so invested in their recovery and time and effort and family and their hopes and everything. And yet this illness of addiction, if you will, is it's really difficult. It's really hard. People who are doing well, all of a sudden they're not doing so well. So anyway, I guess I would recommend it. You can find it. You can find it, I imagine, through going to the FBI, but you can also try and find it on brattleboro.tv.org.
And what's the name of that one?
Chasing the Dragon, which I used to think was smoking opiates. I think that's what it was.
I think that's the original meaning of the term.
Right, but this was really much more about the opioids, opiates, heroin, and the price, and it was mostly, I don't want to say middle class, but you had that sense that it was, people in the papers and everybody's remarking that, heroin addiction has been in the inner city for a long time. It's been a scourge of some minority populations. And now, and only now, that it's really affected the white middle class, that you see this outpouring of compassion almost. Yeah. They need treatment, not jail, and how can we do this? And
getting away from being a crime, being a moral issue, and though people say this is a little bit late, but if this maybe helps us to stop this unsuccessful idea of a war on drugs and turn it more into a social and a health issue, then we're going to see better results.
Well, we could talk a little bit more about that. I mean, because I used to think that part of the problem was a lot of young people in New England and rural New England were sort of naive about opioids, especially when they started off with perks or they started off with splitting an oxy or things like that. And probably these same people would have said no if you said, do you want a bag of heroin? But they were willing to do pharmaceuticals. And then as they shut down that faucet on pharmaceuticals, and it gets more and more difficult to find, and they're very expensive. I remember they were getting anywhere from $70 to $90 for an 80 milligrams oxycodone. Is that right?
Yeah, oxycodone.
Yeah.
Right, yeah.
And then now they found heroin, and it's cheaper. You get more. You get bigger bang for your thing. So anyway, we can talk some more about that.
Yeah.
One of the things I want to mention, next week we're going to have a representative, Mike Hebert, and he represents Vernon and Guilford in Vermont. and he's agreed to come on the show and talk a little bit about the legislation that's going through.
He's a Republican, and he's in the House of Representatives. And one interest is the sort of health legislature that happens to be in the mix right now.
Right.
I mean, a couple of things. I mean, we mentioned the marijuana, but also there's the idea of raising the age for tobacco products to 21 years old, and
increasing the tax on vapor, or on the
So treating the e-cigarettes as more of an issue, which it strikes me as reasonable, given that it is just a different delivery system for nicotine, and therefore has the same potential then to cause addiction to nicotine, which we're seeing, especially in young people, tends to have a crossover effect that they start these very cool e-cigarettes and the vapors and the flavors, and what happens is then they develop dependency on nicotine, which then they often wind up satisfying with cigarette smoking, and then they sort of, rather than the intended, so what we're seeing is not always the intended idea of these vaping or e-cigarettes helping people stop smoking. It actually appears to be helping people start smoking, or to even help them develop a larger habit, smoking more cigarettes per day, or taking in more nicotine in the course of a day.
And I hate to make this a Democrat-Republican thing. And Mike Hebert, he runs unopposed in the last 2 elections, I think, and because he represents the people's interests of both of those communities, and I think he does a good job. But it does seem to be splitting, that the Republicans are sort of not all on board here around legalizations, and the Democrats, especially under the leadership of Governor Shumlin, and and our 2 local senators are Democratic, and both of them are in favor of legalization. So, but he's going to come on and talk a little bit about it. It's really no longer in the community; it's now in the legislature. The legislature works on a fixed schedule, if you will.
Right, so there's no more public hearings. It's all going to be the work of the...
At least for now. Yeah. And so I've been following it on Vermont Digger, which I find is really good for tracking stuff in Montpelier, news that affects, and obviously you can find that on the internet.
Yeah, and I think a lot of folks are familiar with our position that we think now is not the time, that the state has not done the preparation necessary to even consider something like this, especially it being contrary to the idea of making cigarette smoking more difficult, addressing this opioid epidemic, that there's just this inconsistency, but we also want to increase the use of marijuana and all the things that happen there. But really intriguing from the Vermont Digger is the sort of the game playing that goes on, and how this is, despite what people are claiming, this is not really an open conversation. It's not being part of a national conversation, but rather seems to be very sort of special interest and I should dare say peer pressure like and designed to get votes, I'm afraid.
It seems like they want to get this bill that passed out of the Senate into conference. And I just have to read this, and I'll let it go after this. But Representative Vicki Strong from Irisburg, she's a Republican, she said the process was rushed, and she would have liked more time to look at the amendments. And then she goes, so in the end, I supported what's in the bill. I'm very worried about, this is a quote, I'm still very worried about the games that go on here. She says, I'm worried about what will happen to the bill in the Senate or in a conference committee. And this is again another quote. She's concerned that, quote, behind closed doors, things are going to happen that we hadn't really planned on. And again, so, and this is, they say legislation is like
making
sausage, right? You don't want to say, but this is actually the process. And it's sort of interesting. And I think everybody, if they're interested, should know. Representative Sears, Senator Sears from Bennington County, he's now on board with that, and sort of one of the advocates. And he's feeling like, we have a long way to go, quote, a short time to get there. But it feels pretty positive that he can get there. And over here, they say Governor Shumlin is oozing confidence that some kind of marijuana legalization bill will wind up on his desk by the end of the session. So, I mean, there's a lot going on here. I mean, whether the governor is endorsing it, and very other people are asking questions. So I look forward to hearing what Mike has to say. And, and it's not just, I really mean this. I hope it's not just a Democrat-Republican split. because it's going to affect everybody in the state, and it shouldn't just be about revenue.
I'd like to think there's been such a thorough consideration around the real issues and thought to people's constituents, as opposed to the idea of pandering for votes, and the idea that there's this momentum, and now's the time. Which, if you've ever begun advice against fighting against buying something you don't want, you don't fall for that now or never sort of sales pitch, which really seems to be a part of this that's concerning. I'm really curious to hear what he's going to say about that whole political process and gamesmanship and how it really works, this creation of bills.
So we'll see how that goes, and I look forward to having him on the show.
Yeah, so it'll be next week. I'm looking forward to it too.
Okay.
Yeah, and of course, opiates are always in the news as well. You know, we've seen a lot of press in a way sort of blaming doctors still, and that doctors need to rein in their prescribing practices, and you know, on the one hand, sort of thinking we need to remember that doctors are trained to sort of, you know, to do what's the best treatment, and was sort of pushed on the medical field by pharmaceutical companies and then sort of, you know, professional governing bodies that accredit hospitals, for example, that you weren't giving good care unless you prescribed a lot of these medications. So in a way, there's a bigger picture here with the pharmaceutical interests and how they then swayed the governing bodies. That you know, so unfairly, I think doctors have been blamed for this, but definitely there's some new guidelines from the CDC, or the Centers for Disease Control, that is a sort of focusing on the doctors, but I think in a fashion that is saying, look, we have new information, and here are some ideas about how to safely use these medications, now that we sort of are learning more and more about that because of what's happened by the overprescribing of them.
Yeah, and you get, you know, people saying, you know, they want to treat pain. I mean, it's that whole, you hate to say this, pendulum, right? How many years ago, 10 years ago, they said we're not treating pain sufficiently. Yeah. We're not identifying it, we're not treating it. And from that, it snowballed into big pharma and developing, and, you know, extended release medication for cancer patients, blah, blah, blah. You had that whole thing. And now we're at the other end where we have people saying, we're not even going to prescribe pain pills anymore.
Right. There are medical practices saying that they're out of the opiate prescribing, that it's the risk outweighs the benefit, that ibuprofen is a wonderful medication, which it is, very, very effective. And in a way, that's just another sort of reaction, as opposed to a more considerate and in-depth evaluation of the patient's experience and needs.
Right, but at the same time, I mean, it's almost, first of all, it's all about the drug. And you know, what I mean is, like, they're focusing on heroin or they're focusing on pills, but it's people taking them. You know, it's people making choices about taking them. I mean, the day that nobody knows what they're getting into when they start doing opiates is over. People now know what they're getting into, and I really believe that. I don't know, maybe some people still don't know about it, but I sort of doubt it. And when you look at it, you know, whether it's coming from Afghanistan or it's being grown in Colombia or whatever, I think you still have to look at the fact that people are making the choice to use it. People are making that decision to use it. And we really need to sort of understand, blaming the doctors, blaming Big Pharma, pointing the fingers at the warlords in Afghanistan or whatever it might be, you know. I think we have to look at other things. We have to make some decisions about that. So I don't know. I hope that comes up.
Absolutely, because it's complicated.
It
and
is.
You get this sense that sort of politically and socially we can't handle complicated, and we're going to zone in on the heroin coming in there, and we're going to zone in on the way the doctors prescribe that, and not recognize this, say, as a social issue. I've talked to sociologists who talk about, look, one of the problems with this approach is that we're not looking at the broader problem. You know, we're not looking at sort of lack of opportunity. We're not looking at poverty, which, I mean, granted, we're seeing that the opiate problem goes across, you know, all sort of, you know, socioeconomic classes, but we ignore the fact that it devastates the disadvantaged at a much greater fashion than it does other groups.
But when you have a son or a daughter die from this disease, it doesn't matter. how much money you have,
then
or where
we're
you
all
live,
together.
or anything else. And that's the great tragedy also.
Yeah.
You know, the number of people who have died from opiates,
Yeah.
overdose. And, you know, getting Narcan out, you know, now people see that as a solution. You know, well, we need to get more and more of this drug that helps, you know. Again, you know, it's that focus on, well, there's a solution. And you know, it's like, I understand they want to refer to it as an epidemic, and you know, I get that. But it's not. It's not contagious. It's, you know what I mean? It's people making decisions and choices. It's people who are using and getting into trouble with it. And so, you know, you have to go a little bit further with that. And that's why the other thing, I think in some ways, in that you know this, you know, part of, like, we can switch people from street drugs to pharmaceuticals, from medications, whether it's Suboxone or methanol, but there needs to be more. They need to move further along. It's, you know what I mean? It's like, okay, we'll get you involved and get you away from breaking the law and everything else, but there's still more to it than just focusing on, like, we'll give you this drug instead of you buying that drug.
Yeah. And I mean, absolutely. I mean, some people enter treatment for just that reason, right? Just get me some legal opioids so that I'm out of that game there, and that's, I mean, you can fix
but
that.
Even that's a good first step, isn't it?
Well,
I mean, it gets them in the door.
That's the first step. That's the first weeks. I mean, you can actually, you know, within a month, certainly have people on a dose that works, and then you have eliminated that problem effectively of having them go to the black market, have them do all that sort of, you know, illegal economic activity that takes just to maintain a habit. But when you look at, you know, more recent literature and what people know from experience, we're talking about a commitment of years to really help people really get their life back together and develop a quality of life that at least gets them to a point where they are less likely then to return to drug use as they age.
And I just can't help thinking that, you know, and I don't know how successful prevention programs work. I'm not sure about how some of this works. I don't know anything about it, I guess. But the idea is that people are, like, feel entitled to feel good. The purpose of working is to get money to feel good. I mean, you know, and I'm not sure about that. I mean, I heard recently, I forget where it was, but they were talking about this idea that we feel good is a 20th century invention. And it was fed by pharmacy and advertising and everything else. That, you know, there was the idea of working hard, the idea of living with suffering, of living with hardship. The idea that you take a drug or something from the outside to make you feel better, and that's the idea. I wonder if that's something that needs to be addressed. I mean, and how do you address it? I'm not
and I'm thinking,
sure.
I think a similar issue with the prescription of antibiotics, for example. You had some sort of, you know, cold respiratory infection, and what you said is, look, hey, doc, give me an antibiotic, and doctors are prescribing the antibiotics until we got this recognition that most respiratory illnesses are viral. And so if you give somebody an antibiotic, you're not doing anything to the virus, because antibiotics kill bacteria, not viruses. And so the viruses were just, you know, not affected by this. But what you were doing is you were introducing antibiotics to the bacteria, and those that survived were stronger, and that's the basis for resistant, you know, antibiotic-resistant bacteria.
Right.
As I think what we're seeing here as well, you know, talk about these guidelines about being more upfront about risks and benefits, being more judicious about lower doses, shorter periods of time, evaluating the risks and benefits after you've started the treatment. That I think we're at a similar point where we recognize, you know what, opiates aren't the treatment for every single pain. They're for certain sort of situations. Some pains you're going to have to feel. Some are not addressed by opioids, and there are other sorts of treatments to engage in, like, you know, intestinal pain and nerve-related pain are not effectively treated by opioids. And so I think, again, we're going to see sort of better education happening across the whole population, and people might stop asking for these, might stop having the expectation that they should have opioids. And so I'm hoping, as we see, you know, problems rise and fall away, that we might start to see that with the opioids as people begin to realize that the risk-benefit equation and the appropriateness or inappropriate situations to prescribe them.
Right, and you know, I have the idea of medicating extended release, long-term release for people who are struggling with cancer or any painful, where you're really not worried about them becoming dependent long-term. I mean, this is, I don't want people to suffer, but I think we need to stop and take another look at how we think about opiates and how we think about feeling good and not having, learning alternative methods to treat ourselves.
And whether we're promoting suffering as opposed to relieving it.
We could talk about this some more. I'd like to ask you as a doctor, I mean, recently I used a comparison. I don't know if analogy is the right way to think about it, but I said, if you looked at diabetes and you said there was type 1 and type 2, well, one of them needs insulin, if you will, right, to be healthy, to be normal. Maybe there are some addicts that need to be long-term on some kind of opiate medication-assisted recovery therapy. I mean, but there's the other type of diabetes, which really talks about changing a lifestyle, change a diet, exercise.
Associated with obesity and diet and changeable factors.
Changeable factors that you can learn to control and you can do it. And I think that's true for a lot of addicts. I mean, there are 12-step programs. There are things that work. There are things that they may not give you the immediate benefit of taking a drug, but long term, they are going to make a difference, and that you can live without opiates in your life. And I think right now, there's been a focus of getting people off heroin, or and getting them on prescribed medication, getting them into the thing. But I think on the other hand, we also need to be pushing this idea that there's a recovery from it.
Again, not one size fits all, not this very narrow perspective, but to have a very sort of broad appeal. Now, before we move on, though,
go ahead.
What we've been seeing too is sort of maybe a warning about fentanyl.
Oh yeah.
Because for example, a lot of clinics now, I mean, in my practice in Bennington, as well as the methadone clinic here in Brattleboro, we're having discussions about this, and fentanyl being so prevalent now, we're actually starting to sort of test that as a screening for drug use. And so it's definitely out there, and people should be very careful about, well, I mean, again, it's one of the concerns about heroin use is you never know what's in there. But we read an article in the newspaper about basically Chinese criminals are producing large amounts of fentanyl tablets that they're falsely labeling to resemble OxyContin 80 milligrams. And they've got this off sort of color that sort of is a signal that you're getting this. But really, it's very dangerous stuff.
Oh yeah, and it was in the Boston Globe, so if you're interested in today's Boston Globe, it was about that. And again, we're pointing fingers at China, which people are doing. But again, it's that idea that there's money to be made. They're selling pill presses, how to make pills, press them and stuff. But also they're sending counterfeit opioids. And they're really fentanyl. And fentanyl is deadly. It's deadly. So
absolutely.
Okay. Why don't we do that schizophrenia?
So we were in New York. It was very fascinating. This an Indian doctor, Mukherjee, I think was his last name, was writing about sort of family heredity around schizophrenia, which made him interested in looking at sort of research and what's been going on there, and found a really sort of fascinating idea that some natural processes that then are over-accelerated play a role in the development of schizophrenia. And what he was looking at was, as we're in the womb, and as we go through childhood, we create a lot of neurons and synapses, which are the connections between neurons. And then at a point, we start to sort of prune those away. And part of that pruning is considered to be an important part of our learning, our personality development, our intelligence, and this happens at a natural pace, and it can go on for like the first 3 decades of life. This happens up to a point of about 30. So some people were doing then also studies of genes and trying to find clusters of genes that seem to be more common in people with schizophrenia. And what they found was that there was this much greater clustering of genes associated with schizophrenia that happened to be in the immune system areas of our genes.
That was a big study. I think it was 6,000 people, 3,000 controlled and 3,000 schizophrenics or something.
Right, yeah, and so they were able to see sort of the level of these variations of these immune system genes in people without schizophrenia and people with schizophrenia. And what they found out was there's some signaling going on that seemed to cause what are called microglia to be attracted to more of these nerves and their connections to synapses, and was starting to sort of prune those, or sort of take them away, because the microglia are the piece of the central, the nervous system, the brain, that is responsible for sort of being the trash collector, right, taking away junk and bits of unneeded things. And something was going on to get this process to go more quickly in people with schizophrenia, and that was sort of then what happened was sort of loss of reality testing, ways of thinking, and disconnection from other people.
I couldn't help thinking, I had a little experience with trees, fruit trees, and good pruning is essential, and knowing what you're doing and pruning it the right way. But if you prune the whole tree, and you have nothing but trunk left, it's not going to work.
There's nothing
there. There's no fruit. I mean, so it's a process that you learn. But the other thing that struck me about that article was he was writing about his uncles, family history. It looks very genetic. We've always known that. It runs in families. And one of the things, all his uncles were different characters. One was one way, one was the other. And toward the end of that article, I couldn't help noticing that he was saying, in discussing it with his father, and his father being like last generation, like 70, 80, but his father was talking about they're individuals.
Right.
And at what point, and I think this is what he was saying, I mean, I didn't get the science so much, but he was talking about his family. At what point do we go in there and we start normalizing what gets shredded? That whole idea, that people are we going to take away individuals? I guess you have to reread that a couple of times to get it, but it sounds like that's what they're getting to.
Yeah, because the idea was you could detect these proteins, and then maybe develop medications would target these proteins, so that then they would no longer have that sort of marking or signaling on the nerves and their connections, that would then bring in the microglia to basically gobble them up and get rid of them, to prune them out of there. And already made the point. So when this happens, how much do you lose the individual? Because I think the word he used around genes was a Bengali word that meant indivisibility. In other words, this is who you are, and the age-old question of how much does man muck around with nature?
And this is good research. I mean, these are people at Harvard and I think Stanford. I mean, this is really, it was in the New Yorker. It was the issue of March 28, 2016. And the author is Mukherjee. And if you have any interest in all, I mean, I think it's worth finding it and reading it. I mean, it was quite the eye-opener. Like I said, I had to read it twice. I still don't think I understand all of the idea of shedding, pruning, if you will. And they even talk about work that was done with vision, and understanding how that process worked. We were talking about this, and so
it was like a detective story.
Right, but what gets interesting is that I think a month ago we talked about the book that I was looking at in the library that said, is mental illness caused by medical problems or viruses? I forget how it was, but forget about psych, forget about all these ids and everything else. Maybe there's like physical something going on there.
Well, I mean, it's interesting when you consider that people said that, what's called sort of our flora, which is basically the bugs that are within our body. If you look at your gut, good digestion depends on there being certain sort of bacteria or good bacteria in there, and some people are estimating we have more of those than we do cells. And so the idea that the immune system, which is part of which bugs we keep and don't keep, could be part of something large like this is it's just fascinating.
So people really need to read that. We got 1 minute left, and I just I have my favorite thing.
You have to do this.
Is spirituality. And in the New York Times, March 17th, it said, "God is a question, not an answer." And this was an article by William Irwin, and I just thought it was a really great article. And we'll talk about it again some other time.
Okay,
but if anybody's interested in the topic of spirituality and ways of thinking about it, I would recommend it.
Right. I mean, definitely that doubt is a very important part of developing one's faith and spirituality.
It's exactly that. It's the questioning, it's the wondering, it's the doubt, and that's what faith is. And to have this open, ongoing discussion about it, and not to say this is the answer or this is not the answer.
All right.
True believers.